With this presentation, I would like to answer a question that comes to the mind of many surgical uro-oncologists, whether during radical cystectomy we have to do a standard or an extended pelvic lymphadenectomy. Whenever we are going for a surgery, usually we tend to go one step ahead. If the patient is an MIBC, we do a standard lymphadenectomy, thinking that there might be microscopic spreads. Or when we do RARC for a N1 or N2 disease, we tend to do a extended lymphadenectomy, thinking that yes, one step ahead, there might be micrometastasis. This is a common notion among many surgical oncologists. And to answer this, a SWOG trial was done, which was a phase 3 surgical trial to evaluate the benefit of a standard versus an extended lymphadenectomy performed at the time of radical cystectomy for an MIBC. The hypothesis, like I mentioned before, was that extended lymphadenectomy improved disease-free survival, overall survival, compared to a standard lymphadenectomy in a localized MIBC. The objectives of this trial were to compare, primary objective of this trial was to compare disease-free survival in patients undergoing radical cystectomy versus standard versus extended pelvic lymphadenectomy. The disease-free survival was defined as the first documented evidence of recurrence or relapse or death due to any cause. The study also evaluated secondary endpoints, including overall survival and post-op morbidity. The study design. Now, the randomization in this study was done intraoperatively. The study included all patients from T2 to T4A, since T4B is inoperable, and NO, N0 to N2 stage. N3 was not included because extended was offered to all N3 patients, and performance scale 1 to 2. The randomization was done, like I mentioned, intraoperatively, where patients were taken during pelvic lymphadenectomy, and a frozen section was sent for extended lymph node packet. If the frozen section was positive, then the patients were excluded from the study and extended lymphadenectomy was done. However, if the frozen section was negative, the patients were intraoperatively randomized into standard versus extended pelvic lymphadenectomy. In the final histopathology, patients with T3, T4 or any N+ disease were offered adjuvant chemotherapy, but it was not a standard treatment. This is the consort flow diagram, where a total of 618 patients were included, which gives the power to determine the difference in disease-free survival of 10 to 12%. Standard lymphadenectomy was done in 300 patients, and extended lymphadenectomy was done in around 292 patients. The median follow-up was 6.1 years, which speaks volumes about the follow-up protocol in the trial. Now, there is pre-randomization covariates in the patient population, and they were further categorized into different categories to remove any confounding bias. As we can see that the pre-operatively, around 70% patients were T2. There was definite hydronephrosis in 25% patients. And this trial included both patients treated with neoadjuvant and with non-neoadjuvant therapy. However, as we can see from the slides, that approximately 57% patients in the trial had been offered pre-operatively neoadjuvant chemotherapy, which is also a good marker of the multidisciplinary team management done in the SWOG trial. Again, stratifying the patients into after the cystectomy with the histopathology, approximately 20% patients were YPT0N0, and approximately 17 to 20%, which is usually 15 to 20% patients were finally YPT2. Now comes to the histopathology of the pelvic lymphadenectomy. As expected, the extended pelvic lymph nodes, during extended pelvic lymphadenectomy, the total number of nodes removed were more. The average number of nodes removed in a standard were 24, and the extended were 39 because we are removing extra packets. However, the number of positive nodes, if the tumor was N+, is almost similar in both the cases. As expected, the estimated blood loss in an extended lymphadenectomy is slightly more than the standard lymphadenectomy. Now comes our primary endpoint, which is disease-free survival. In this graph, we can see, although it was expected that the extended lymphadenectomy would offer a better disease-free survival in patients. However, with a 6-year median follow-up, it was found that there is no significant difference in the disease-free survival whether we offer a standard or an extended pelvic lymphadenectomy. However, like I mentioned before, we have categorized the patient into several categories to remove confounding bias. And like I have highlighted in this chart, it was whether we give neoadjuvant therapy, whether we do it for a T2 or a T3 or a TIS, the difference in disease-free survivals were not significant. However, in patients with a PT3, T4A, and 0 patients, there was a significant difference in the disease-free survival. But this hypothesis needs to be further evaluated. Coming to the secondary endpoints, which include the adverse events, as expected, the Clevin-Dindo grade 3, grade 4, grade 5 adverse events were significantly more in the extended pelvic lymphadenectomy packets. The major complications which were more included sepsis, wound infections, and thromboembolic events. So to conclude, the patients undergoing radical cystectomy and expanded pelvic lymphadenectomy had increased node yield, but similar pathological T stage. Extended lymphadenectomy was associated with higher number of positive nodes among N1 patients and with higher N3 stage. But there was no significant difference in the disease-free survival and overall survival for extended pelvic lymphadenectomy compared to patients undergoing standard lymphadenectomy. So although also extended lymphadenectomy was associated with the greater morbidity and higher perioperative mortality. So the standard of care based on this trial is bilateral standard lymphadenectomy for patients with T2 to T4A and 0 to N2 urothelial cancers, which are offered radical cystectomy. Thank you.